Good day, respected dean, faculty, judges, and to my co-student. I am Ariel Villacarlos, 6-year College of Dentistry student. First off, I'd like to say that when we treat our patients, we try to be caring. Thus, my quotation says, complete denture, complete care. Because the new life begins with a confident smile. My case report is titled Prosthesis Replacement After 30 Years. For the abstract, complete dentulism, although not inevitable, is a condition that is very common for Filipino geriatrics. And we all know that given the poor dental health system and poor financial capabilities of majority of the population in the Philippines, many individuals resort to using their dentures for a longer period of years, exceeding the recommended span by the American Dental Association, which is 5 to 7 years. And now we presented in this case report is a 72-year-old grandmother with a perfect health during the time being, with complete dentulism and uses her complete denture for 30 years. So, step-by-step procedure was done, starting from preliminary impression up to installation and also the follow-up. Uh, for the introduction, the challenge in dental practice continues to be the successful management of the complete denture patient who experiences a ongoing difficulty with her or his denture. What is complete denture? Complete denture is a removable prosthesis that replaces all missing teeth in either or both jaw. According to the study, the most frequently observed fault in denture construction are related to retention and vertical and horizontal jaw relationship. We should know that a good complete denture must possesses all the makeup and structures needed to make the prosthesis retentive, stable, aesthetic, comfortable, and biocompatible. So when the patient seek dental treatment, her chief complaint was, nahihirapan akong kumain, maluwag ang pustiso ko, lalo sa ibaba. Which means I have difficulty eating, my lower denture is loose. Medical history, she's not taking any medication, she doesn't have any systemic disease nor known allergies. Her family has no history of serious diseases. For the dental history, she has been a dentulous for more than three decades. She was still wearing her old denture until the first appointment. Uh, According to her, her teeth were all extracted for the reason of carious lesion. Maxillary arch was first to be edentulous. And also, she said she rarely wear the mandibular denture because of looseness. Her denture was constructed 3 years ago, 30 years ago. Now, for the extraoral observation, you can see in the picture that she has a convex lateral profile, diamond facial shape with a very prominent zygoma, retrognatic mandible, increased nasolabial angle that you can see here in the lateral view, distinct nasolabial fold, uh, and a class 2 skeletal pattern based on the convex profile of the patient. As we go now to the intraoral observation, there's a significant bone recession in her lower ridge. Anterior lower ridge is thin. As you can see in the first photo, genioglossus muscle almost same level of the anterior lower ridge. Her upper ridge has prominent maxillary tuberosity. Anterior papillae sit slightly anterior to the ridge. The color of mucosa is generally pink, and the palate represented a with a denture stomatitis. That's why we immediately advise the patient uh, not to wear her old denture anymore. So the diagnoses are complete edentulism and denture stomatitis. Because the patient was very positive and very uh, motivated for her dental treatment, she was cooperative and always patient. Her denture can easily be constructed, and an excellent outcome is our prognosis. So for the treatment procedure and discussion, first we took a preliminary impression using modeling compound. From there, we constructed a preliminary cast which we also studied, and where the acrylic custom tray or individual tray was patterned. Using the customized tray, final impression was taken with the use of light body for the lower and alginate for the upper. And a master cast was constructed with the use of die stone. With the master cast, I then made an ideal occlusal rim, but I also considered my patient profile while shaping it, especially on the anterior surface of the maxillary denture. On the following meeting, trial fitting of occlusal rim was done to establish the vertical and centric relation. The bite was locked, and the upper and lower master cast was articulated. Posterior occlusal plane. When considering the posterior occlusal plane, we have to remember the importance of proper orientation of the occlusal plane, which are the aesthetics, function, and denture stability. In doing that, the alatragus line is our guide by using a Pax plane. Alatragus line is also called Camper's line. It is a line running at the inferior border of the ala of the nose to the superior border of tragus of the ear, as you can see in the photo. It was used as guide to establish the posterior occlusal plane. Now we go to anterior occlusal plane. Anterior occlusal plane plays a significant role in developing again the aesthetic and now with the symmetry and harmony. In doing that, our guide this time is the interpupillary line. Previously, for the posterior, it is the alatragus line. Now, for anterior, it's interpupillary line. Uh, it is it is a line connecting the two pupil or the outer canthi of the patient eye. The occlusal plane of maxillary anterior teeth was made parallel to the interpupillary line. After establishing the vertical dimension of the occlusal and centric relation, uh, the master casts were articulated. From there, I was able to set the pontic by just following the guide, which is my occlusal ring, with the midline, canine, and high lip line markings. The trial wax denture was then tried and fitted to the patient, and it was satisfactory. Thus, we proceed to the processing of the denture. This is the before and after denture delivery. The retognatic mandible is not so obvious anymore. The nasolabial angle was reduced because of the lip support provided by the denture. The nasolabial fold was quite the same, but I think it is because of the very prominent cheek or the zygoma. We also tried to compare the old denture and new denture. On this view, the two differs when it comes to the extension of the denture flanges. The old one is underextended while the new one covered the vital part of the maxilla for a good retention. You can also notice a lack of occlusal anatomy with the old one, which is not very good, especially when it comes to denture stability when in contact. They also differ when it comes to fitting and seating of old denture with recent patient cast. Same problem with the mandibular denture. There was lack of extension of the denture base to the retromolar pad. and extension of lingual denture flanges, which are very important for retention, which was part of the chief complaint of the patient. Uh, when it comes now to the vertical height, the old denture has decreased vertical height. In anterior protrusion, old mandibular denture has has more upright lower incisors, unlike in the new one, where I slightly protruded to give an illusion of an prognatic mandible. For the conclusion, there is a significant relationship between inadequate retention and improper intermaxillary relationship, and patient complain of looseness and difficulty eating, respectively. In this case of a 30 years of using the same denture, the patient vertical height, ridge width and height, and even the soft tissues changes. It was anticipated that eventually the denture will be unretentive, will be causing soft tissue trauma and irritation. Thus, the ADA recommendation of denture replacement after 5 to 7 years. Uh, Extension of denture-based flanges affects retention. Extension of denture base to the retromolar pad areas, and buccal shelf will result to less stress load to the residual ridge, secondary stress bearing area. Thank you, everyone. These are my references, and thank you again, and have a good day.